Okay, so the discussion one is selective TYK2 inhibition for the treatment of psoriatic disease. TYK2 inhibitors are a promising new oral treatment for psoriasis and psoriatic arthritis. TYK2 mediates type 1 interferon and IL-23 signaling, thereby amplifying IL-17 production, which drive psoriasis and psoriatic arthritis pathogenesis. There are two categories of TYK2 inhibitors: allosteric inhibitors and orthosteric inhibitors. Allosteric inhibitors bind to a regulatory pseudokinase domain on TYK2, altering the shape of the enzyme to prevent ATP binding, locking it in an inactive state. Examples include deucravacitinib and zasocitinib, that is in clinical development for psoriasis and psoriatic arthritis. Orthosteric inhibitors compete with the ATP for binding to the active site of the catalytic domain, and examples in development include brepocitinib and ropsacitinib. Deucravacitinib has been approved for the treatment of moderate to severe chronic plaque psoriasis, and the approval was based on efficacy demonstrated in the PsOPsA trials. In particular, PsOPsA1 and PsOPsA2 are 52-week double-blind phase 3 trials comparing the safety and efficacy of deucravacitinib versus apremilast and versus placebo in adult patients with moderate to severe psoriasis. Response rates for the co-primary endpoint, PASI 75 and physician global assessment at 0-1 at week 16, were higher with deucra versus both placebo and apremilast. And in the histogram, you can see the response rate of PASI 75 at week 52 with deucravacitinib, that is 72%. And at week 112, that is 79%. So it increases over time. PsO long-term extension is an ongoing phase 3b open-label trials evaluating the long-term effects of deucravacitinib in adults with moderate to severe psoriasis who completed PsOPsA1 and PsOPsA2. Long-term treatment with deucravacitinib maintained or improved efficacy in patients up to week 112, compared with the start of the extension trial. Deucravacitinib has been also investigated in psoriatic arthritis in phase 2 and phase 3 trials. On the left of the side of the slide, a double-blind phase 2 trials evaluated the efficacy and safety of deucravacitinib in PsA, and the primary endpoint was met. A CR20 response was significantly higher with the deucravacitinib 6 mg day and also 12 mg day versus placebo at week 16, in particular with the dose of 6 mg day, that is the dose approved for psoriasis. The ACR20 is achieved by 52% of patients. Deucravacitinib was well tolerated, with safety findings were consistent with those reported in the study of psoriasis. The phase 3 PsA1 and PsA2 trials are evaluating the efficacy and safety of deucra in PsA, and both the trials met their primary endpoint, with a significantly greater proportion of patients treated with deucra achieving a CR20 response rate at week 16 compared to placebo, and in particular the response rate was 54% ACR20 at week 16 compared to 41% with apremilast and 39% with placebo. Zasocitinib is a novel allosteric TYK2 inhibitor. Is in late stage clinical development for both psoriasis and psoriatic arthritis. in this table, you can see all the study, clinical trials, and the phase, and the comparator arm, and the population, and the status of the clinical development of zasocitinib in moderate to severe plaque psoriasis, in GPP, generalized pustular psoriasis or epidermic psoriasis, and also in psoriatic arthritis. The completed study is the phase 2b study, zasocitinib versus placebo in patient with psoriasis, and also the study, phase 2 study, zasocitinib versus placebo in patient with psoriatic arthritis that is completing. The other studies are active, recruiting, or ongoing. This is the phase 2b trials. Study design and patient population is a randomized, multicenter, double-blind, placebo-controlled trial evaluating the safety and efficacy of zasocitinib in patients with moderate to severe plaque psoriasis. Inclusion criteria, of course, adult patient. The definition of moderate to severe psoriasis is PASI score greater than 12, physician global assessment greater or equal to 3, and BSA greater or equal to 10%. A total of 259 patients were included and randomized with a ratio 1 to 1 to 1 to 1 to 1 to the dose of zasocitinib 2 mg, 5 mg day, 15 mg day, 30 mg day, and placebo. And the primary endpoint is the PASI 75 response rate at week 12. Secondary endpoint are PASI 19, PASI 100, physician global assessment at 0-1, and of course change in DLQI, and also safety and tolerability issues. At baseline, the mean PASI score was 18, the mean BSA was 22. And 16% of patients had received prior treatment with biologics. So you can see the primary endpoint, that is week 12, PASI 75, PASI 19, and PASI 100, and physician global assessment 0-1 response rate were higher in patients with treated with zasocitinib 5 mg or the other doses, greater doses versus placebo. And in particular, with the dose of 15 mg, the PASI 75 response rate was 68%, and a similar proportion with zasocitinib 30 mg, 67%. So no difference in DLQI was seen with zasocitinib 2 mg versus placebo. However, 5 mg or greater doses showed an improvement from week 8. Greater and early improvement from week 4 were seen with the dose of 15 mg and 30 mg dose versus placebo, which was sustained through week 12. In terms of safety, this table summarizes the treatment emergent adverse event occurred in the placebo arm and the zasocitinib arm. And the most frequent treatment emergent adverse event included COVID infection, but all events were grade 1 or grade 2, moderate in severity, acne and acne for dermatitis, and diarrhea. And you can see the absolute number of events observed in the study population. So zasocitinib in psoriatic arthritis, this is the study design of phase 2b trials and also efficacy is a randomized, multicenter, double-blind phase 2b trials where randomized 290 patients and with zasocitinib 5 mg, 15 mg, 30 mg, and placebo. And the primary endpoint was ACR20 at week 12. That was achieved by 53% of patients treated with the dose of 15 milligrams and 54% of patients treated with a dose of 30 milligrams. And the primary endpoint was met. in a significant proportion of patients treated with zasocitinib 15 milligram and 30 milligram versus placebo. In terms of safety, the most common treatment emergent adverse event in patients treated with zasocitinib were nasopharyngitis, upper respiratory tract infection, headache, and rash. And the safety profile was consistent with the study on psoriasis. So these are the discussion points. They are related to when would you select TYK2 inhibitor as a treatment option of psoriasis. This is just a question that has our therapeutic algorithm has changed thanks to the TYK2 inhibitor. Or would you describe your experience with the deucravacitinib, the treatment of moderate to severe plaque psoriasis, and what do the phase 2b data reveal about the clinical potential of zasocitinib either in psoriasis and psoriatic arthritis? So I think that you are free to join the discussion according to the, how do you like to intervene? I mean.
Maybe I can start, Paolo. Thank you for the presentation. I will play a little bit the devil's advocate here. You see that the PASI 90 response is below 50%, at least in the trial.
Yeah.
And I personally, having now watched the decades of the development of highly effective and very tolerable biologic treatments, I have to ask myself the question if we still need the drugs that have a PASI 90 response below 50, so that only 1 out of 2 patients will benefit from this kind of treatment, together with the side effects that are to be seen, and with the JAK inhibitors and the TYK2 that is commonly available, we really do see a lot of folliculitis, which is not acne, definitely not acne, it's folliculitis. And we see a lot of nasopharyngitis, so general infections, particularly in the winter time here in our region. And we see other viral infections, and this is all with a limited efficacy. We do not see all these facts, for example, with treating with IL-23 P19 inhibitors. So what is the benefit of another TYK2 inhibitor? That is the question I have to ask here.
Yes, thank you, Uli, for this point that, of course, is an important point, and also either in terms of efficacy and also in terms of safety consideration. It's the issues of oral treatment that some patients prefer or feel that an oral treatment is more safe compared to an injectable treatment. Do you think that could be a motivation, a rationale to prefer TYK2 inhibitors compared to an injectable treatment in your experience?
Well, this, according to what I have heard from other people around the world, seems to differ enormously from country to country and region to region. I can
specialty as well.
Yeah,
specialty as well.
I only can give you our experience from Germany, and here the people have been used to injectables for 2 reasons. The first reason I just mentioned, they're very effective. The second reason is, particularly with the P19 inhibitors, they need to give the injections only every 3 months. And in the meantime, they totally forget their disease. When you take a pill every day, you're every day reminded that you have a chronic illness that can't be cured. So there's a psychological background also. If we do shared decision-making with our patients and we offer them a drug that is injected every 3 months, and meanwhile, 9 out of 10 patients are virtually clear and free of disease, or a pill to be taken daily with the potential adverse events and the limited efficacy, I would say 99% of the patients will choose the injectable. But again, this is different from region to region, people, country. And the behavior, as Peter is saying, behavior may be also the counseling of the respective doctors.
So I'll give the rheumatology point of view. The amount of skin disease we see in most of our patients is very low. I struggle to get 3% body surface area into a clinical trial. So you see terrible skin with a little bit of joints. I see terrible joints, a little bit of skin, and then we share the patients who have bad skin and bad joints.
Yeah.
So we need an oral agent to assist methotrexate before going to a biologic, because our government makes us use drugs that don't work, like leflunomide and sulfasalazine, before we can get to a biologic or a target synthetic. We need an oral agent for the patients that can't manage a cold chain. We need an oral agent for people recovering from side effects from biologic agents, in particular TNFs. And in our hands, we don't see this infection. In fact, for us, the deucravacitinib is amazingly safe compared to the other toxic poisons that we like to throw around on a daily basis. So for us, people recovering from a side effect, people with milder to moderate disease, people who now, and I should add another group, is the combination group. We have defining now patients who are treatment refractory and patients complex to manage. And we're starting to combine a traditional biologic with deucra or apremilast in the very difficult patient in combination with our dermatologists, even though it's not on label, because we have these shared patients with very, very difficult disease to treat, and there's very little safety penalty adding deucra to another agent. So we do see a niche for this particular drug.
Thank you, Peter, for having your point of view in a broader. Some other comments related to these. Yes, my point was on the perception of the patient. For some patient, they coming from a topical therapy. When, not all the patient, but selected patient, when I propose a systemic treatment, they perceived oral as more safe than injectable. At the end, could not be true, but the patient perception is different, because oral is perceived as more easy to take. I would like to know other consideration regarding this topic, and if there is an experience with deucravacitinib in patient with psoriasis and psoriatic arthritis. What about the safety? Because according to the data of the trial, the safety is quite good. I mean, it's not so complicated in terms of infection, but according to Uli, his experience was different. Which is your experience?
Sorry, I'm Yukari from Japan. So in Japan, usually patients prefer oral treatment rather than injection somehow. Probably painful or something like that. Oh, I'm not sure, but and usually we prescribe apremilast first. Then if apremilast doesn't work, we choose the TYK2 inhibitor, deucravacitinib. Yeah, but because apremilast is a little bit cheaper than deucravacitinib in Japan, so patients don't want to pay much. So first apremilast, then deucravacitinib. But somehow I feel after treatment of apremilast, if it doesn't work, even TYK2 inhibitor, deucravacitinib doesn't work sometimes. Yeah, so I think we should choose. Recently, we are thinking we should choose TYK2 inhibitor first for moderate to severe psoriasis patients. Yeah.
Okay.
And also,
So you are using apremilast before biologics.
Yes.
And
Yeah.
if the patient fail apremilast, you select deucra.
Deucra, yes,
right?
yeah.
Okay.
Yeah, but
And
of
then
course,
if the,
for example, patients with PsA, we usually choose biologics rather than oral medication.
May I add just one comment, Paolo, to this discussion? In our center, where we meanwhile can look back to several hundreds of psoriasis patients treated with any kind of treatments that are available in Germany, we do regularly drug survival rate calculations.
Yeah.
And our last drug survival survey of our patients show a very, very clear picture. And that is that the P19 antagonists are by far the best regarding drug survival, followed by the IL-17s and adalimumab. Virtually only adalimumab is being used. But there is already a tremendous discrepancy between the P19s and adalimumab. And absolutely the worst is with apremilast and deucravacitinib. So the drug survival of those drugs, even they are used in a more or less same population, ends usually after a year or 1.5. And that's due to many, many reasons. As you know, drug survival is a very complex mixture of efficacy, side effects, tolerability, etc. So from this aspect, and drug survival also is, of course, closely linked to an economic perspective of treatments. There's really no vote for oral treatments at the moment, given their limited efficacy and their range of side effects, which become intolerant for many patients that are treated with those. So that is an argument we are trying to bring forward, because when you again chat or when you discuss with your patients the treatment options, you need these kind of data, because the patients, they want a stable treatment for a long time. They want to get rid of their disease, being cleared from the skin lesions, hopefully from the joint pain if they have joint pain. But that's on their wish list number one. And this best facilitated by using highly effective drugs with a long-lasting drug survival. This just to add to this notion that I made earlier.
Yes, of
Lily,
course.
can you answer for me why we didn't see any of this folliculitis with upadacitinib or in all the RA trials, and yet when you use it for atopic dermatitis, you started to see some of this acneiform stuff, and why you see it with deucra? What's the mechanism for that little bit of folliculitis?
I think the mechanism has not been really clear why it is. It seems that the change of the microbiome is at least part of it, but this are just under discussion. I'm very crude now, Peter, and I say that in rheumatology trials, the dermatology experience to evaluate skin is probably not as good as in a dermatology trial. And we look, hopefully with every investigator, look from top to bottom, and that we are really keen on seeing features on skin that shouldn't be there.
But people complain about this. They will complain about folliculitis. They won't keep it quiet.
It's dependent where the folliculitis is. Usually, when we see folliculitis in these patients, we see a lot of folliculitis, for example, on the buttocks, and that's normally hidden. So it's not pruritic, usually not. But again, this folliculitis do exist. We have really, when you would do a thorough dermatological exam with each and every JAK and TYK patient, you will see folliculitis in a high number of patients, not necessarily limiting the use of the drug because it's not pruritic and it may not bother the patient because it's not in visible areas.
Yes, I suppose for us, we're trying to avoid bacterial sepsis, opportunist infection, TB, zoster, all this stuff. So it's a different focus, I'm sure.
Yeah, I guess so.